All right, here we are with another lesson in anatomy and physiology with Dr. H. Um, we are on our fourth video for hemostasis, and I know I started this off by saying there's only three major phases of hemostasis, and I listed these things off, all right? We're going to stop the bleeding. We need vascular spasm. We need to create a platelet plug formation, and then we need to have coagulation, which is all fine and dandy, but it's good to remember that this all started because of tissue damage. And so what needs to happen is post-coagulation, we are going to be healing that tissue. And once that tissue heals, we don't want the clot anymore. Once this tissue heals, we're going to have to bust this clot up. This is called clot busting. At least that's a fun way to say it. So we want to break down the clot. We call it clot busting. And that's the last little bit that I'm going to be able to leave you guys with is how do we go about clot busting? Well, this all originates with the clot. The blood clot that has been produced, if you recall, is made of a fiber mesh, or more specifically a protein called fibrin, and it has been all bound together into a polymer mesh. So if we are going to break down this blood clot, what we actually have to do is cut up all of this fibrin. Well, the way that it does this is by actually having this clot that has been in the process of healing. This blood clot is going to produce or help with, really not producing it itself, but help with the production of a new protein called tissue plasminogen activator. Why did I put, oh, there we go, activator, which is going to activate this protein called plasminogen. Okay, we abbreviate this as TPA. There is another protein that is produced through this process as well. That is called UPA, which is an interesting little one. That's urokinase plasminogen activator, or UPA. Both of these are technically going to be required in order to activate plasminogen. So both of these are going to be required to take plasminogen, and what? If it ends in ogen, IN of course is an active protein, so if it ends in ogen, it is an inactive protein. So now we're going to be able to take the plasminogen and we're going to cleave off the ogen and produce plasmin. And what this plasmin is going to be able to do is it's going to feed back, because it's being produced around this fiber mesh, this fibrin polymer mesh, and it is chewing this thing up. So it is dissolving the clot. How did this all happen? It happened because the fibrin polymer mesh produced TPA and UPA. TPA is one that we end up using clinically a lot more than UPA because of its specificity. This is going to help to convert plasminogen into plasmin, and this plasmin then is going to go to the fibrin polymer mesh and help to dissolve that thing. So this is the dissolver. And that's about the short and sweet of this. As long as the clot is present, we are in the healing state. Once we are healed, or even before we start to heal, we're going to want to try to get rid of this clot. So we're going to try to chew it up. What is required for that? TPA and UPA, primarily TPA, which converts plasminogen into plasmin, and then plasmin is what is dissolving the clot. A great use of this, or a great way to think about this, is clinically if you have a patient that is a stroke patient or a heart attack patient. These are often or most often occurring because of a blood clot. If a blood clot blocks a capillary in the brain, that's called a stroke. Or if a blood clot is blocking a capillary on your heart, then that often induces a myocardial infarction. So this is going to cause that muscle to go into ischemia and die. That is where heart attacks come from. So now if you have a patient that is a stroke patient or a heart attack patient, we assume that that is caused by a blood clot. So what do we do clinically? We give them TPA. Again, we don't really use UPA much in this particular case. The reason is multifold, but TPA is more specific to the fibrin within the blood clot, this fibrin polymer mesh, whereas UPA is going to be able to activate a lot of other fibrins as well. So it's less of fibrin specific, I guess is what I mean. So it's activating plasmin throughout the entire body, not just plasmin that's acting on a fibrin polymer mesh. So it's going to end up causing a higher risk of systemic bleeding and acute ischemic stroke and a bunch of other crazy things like that. It doesn't cause acute ischemic stroke. This makes it less efficient for treating acute ischemic stroke, where we want really precise targeting, and therefore TPA is what is used in those cases. So yeah, often clinically, maybe some of you have used this already, you use TPA, inject that into your stroke patient, and it is going to activate plasminogen into plasmin, and therefore we are rapidly dissolving that clot. And with that, this video is already done. Thank you for giving it a watch. As I always say, subscribe or don't subscribe, like or don't subscribe. I don't really care. Hopefully you learned something. Humankind, be both.